Thank you guys for coming out tonight. We're going to keep this very casual, so please feel free if you have a question or comment or anything, just don't hesitate to reach out and interrupt. We want to keep this as much of a casual atmosphere as possible. So Dr. McCarroll and I, the way we decided to, because most of us, myself included, feel that these presentations can also at times get boring, what we want to do is just kind of go over the anatomy of the Achilles tendon and the posterior heel, give you guys an understanding of what that part of the body does. And then Dr. McCarroll and I were going to go over the three most common clinical scenarios that a patient will come to in our office setting and talk about some of the symptoms. And then he and I are actually going to talk to you about the way that we treat the injuries. We'll talk to you about the diagnoses and how we approach it, and you'll find that although both of our techniques are very much the same, and we both get to the same end point, we each have little nuances in how we approach each of the settings. So I think that'll be a good way for you guys to get a feel for how we can approach things differently, and so we'll go through the three topics, and then at the end we're going to break the group into half and talk to you guys and do a little bit of an individual type of screening, so that if you guys do have problems that need to be addressed, we can take care of them for you.
And this is supposed to be fun, okay? This is not supposed to be us lecturing to you. Yeah. The best conferences out there that we go to today are conferences where they set the ground rules as you can interrupt us at any point in time, okay? You can ask a question at any point in time, and that way it's more interactive instead of us up here pontificating about what should be done. Let's make it more interactive from that standpoint. So don't hesitate. Maybe just raise your hand so we can get to you at the end of a thought. But by all means, speak up during the course. Don't save it all at the end because you're going to forget what was important to you. Okay?
Great. So the Achilles tendon is a unique tendon. It's certainly considered to be the strongest soft tissue structure in the body. And it's made up of two muscles in the back of the leg. And the two muscles are the muscles that if you were to grab your calf, that you're feeling there in the heart of your hand, and the muscles are called the gastrocnemius and the soleus muscles. And the gastrocnemius muscles and the soleus muscles are these muscles that you see up up top of the leg, just behind the knee. And at about 2/3 of the way down the leg, they start to form what's called a tendon structure, and the tendon structure inserts on the back of the heel bone. And you'll find that the common theme that Dr. McCarroll and I talk about throughout the evening, one of the most common things that you're going to hear about is muscle tightness. And it's the tightness of this complex from basically all the way up here down to the bottom of the knee, or bottom of the heel, that causes most of the problems associated with Achilles tendon injuries throughout the course of a lifetime.
Not only that, but probably 1/3 of the things we see in the office are either directly or indirectly related to that tight Achilles tendon. When that Achilles is tight, you're going to be prone to shin splints, you're going to be prone to plantar fasciitis, you're going to be prone to posterior tibial tendonitis, not to mention just the Achilles itself. So probably about 1/3 of what we see is all related to this not working properly. Go ahead, Steve.
And with that being said, when the Achilles tendon, and you see in this enlargement of the ankle, when the Achilles tendon grows into the heel bone in the back, there's these two little pillow-like structures called bursas that can get inflamed. The Achilles tendon will wrap around the back of the heel and grow into the plantar fascia, and Dr. McCarroll just mentioned plantar fasciitis is probably what we would equate to in our practice as the cavity for the dentist. It is the thing that we see most often every day. There's not a day in the week, I would venture to say, that Dr. McCarroll and I each don't see several people with plantar fasciitis. It's by far the most common thing we see, and it's a direct cause of the Achilles tendon. And then you may or yourself or know somebody that has a bone spur on the back of the heel. and that can occur either on the bottom of the heel where the plantar fascia is, or on the back of the heel where the Achilles tendon is. And those are also directly related to the function and tightness of the Achilles tendon. So the anatomy of the Achilles tendon really dominates almost all of what the foot and ankle does in terms of its ability to, whether you're running or walking, how you feel when you step out of bed in the morning, whether or not it hurts when you take that first step out of bed, whether you feel better in high heels or better in flats. All of those things are directly related to what this structure is doing called the Achilles tendon. So, with that being said, now that we've got a feel for what the anatomy is like, we've got three main conditions, and the three conditions that we see as foot and ankle surgeons, the first one that most people think about is the Achilles tendon rupture, which is when the Achilles tendon structure snaps. And that is probably the one that people think about the most, but it's probably the least common one in the office that we see, I would guess. And both Dr. McCarroll and I see a fair amount of those yearly, but when you think of the other two types of common pathology of the Achilles tendon, by far the Achilles tendon rupture is the least common. Achilles tendonitis is probably the most common thing we see, and it's got entities associated with it called bursitis, which are when those pillows in the back of the heel get inflamed. And then the heel spur associated with the Achilles tendonitis, or the tight Achilles tendon, is also a common thing we see. And then the final thing is called Achilles tendinopathy. And we're going to show you some neat pictures of that because this is something that we see quite often as well. But this is something that is much, much more painful in many situations than your quote-unquote Achilles tendonitis. And it's got a different presentation, and it's something that, that we can, we'll talk about in detail.
What's the difference between the tendonitis and tendinosis?
Sure. Tendinosis is actually having a tendonitis is an inflammation around the tendon. A tendinosis is actually a scarring or a degeneration that occurs in the tendon, often with tendonitis. But you'll often see tendinosis when you start to feel that knot or that thickening in the tendon itself. So when you get an MRI in particularly, and that's where they usually use the term tendinosis, when you get an MRI, you're going to see the normal black structure that's called the Achilles tendon. It's almost always black on all images. You'll see that start to gray or start to whiten. And that's scar tissue forming and tendinosis. And we'll talk a little bit more when we get into micro tears about that process as to how that develops and what's going on with that. It's interesting when we talk about this, we were originally going to talk on Achilles tendon ruptures. And Dr. Brigido so appropriately said, well, that's certainly not a practice builder. By the time you get an Achilles tendon rupture,
it's too late.
Yeah, all your decisions are made. If you have adequate circulation, unless you have severe cardiac disease, we're going to surgery. It's these other things that are kind of the telltale signs that maybe, hey, something's going on, maybe we can help you, and address it then. That's the practice builder, and that's what you guys want. Go ahead.
I've been helped many of times. I've had shots, I've had physical therapy, and it all boils down to tight calf muscles.
Yep, and that's what AJ's going to hit.
It doesn't go away. I've stretched for half an hour every morning after I work out, 6 days a week.
Sure, there are other options. Yeah, there are even things, Dr. Brigido pointed out, the gastroc muscle up high, the Achilles is made of those three. There's I don't want to say it's benign, but there is a procedure commonly done in adults with various types of flat feet, and even in kids with problems, and older adults after stroke or gunshot wound. Sometimes you go in there and you lengthen that upper muscle. Now, it doesn't weaken the whole tendon. You do regain muscle tone, and AJ can probably talk to you about that. But there is actually a surgical procedure that can be done for people that cannot overcome that. People that have chronic tendinosis, have TP tendon dysfunction, which is another tendon in the foot, as a result of that tightness. So there is a surgical extreme to treatment. If we have to, that's not rupture repair. That's actually a prophylactic type of surgery to address that problem. Okay.
And the good news is with technology having advanced as much as it has, a lot of times we can do it. I think when Dr. McCarroll and I both went through our surgical training, we were doing incisions that were this big, and the recovery was so much different than it is today. Now we're doing it through smaller incisions. Many times you can even do it through a camera. Patients are now asked to get into physical therapy a lot quicker. You don't have the type of postoperative course that was counterproductive, so to say, for the patient's quality of life. And this just happened over the last 10 years, and we've seen advancements in it significantly, and it's become something that I think Dr. McCarroll and I would both say we've probably incorporated in our practice more so in the last 5 years than we did the prior 5 years before that, because of the advances of technology. So so when we think about, one of the most common scenarios that we see in our practice is a patient that comes in and they say, we've got this palpable lump on the back of our Achilles tendon. Like we can feel this kind of knot. And some days it gets bigger, some days it gets smaller. Some days when I squeeze it, it gets very painful. Some days when I squeeze it, it's sore, but it's not too bad. When it hurts, it feels like I have either a hot dagger going into my Achilles tendon, or I feel like I have almost like a toothache or a soreness of the back of the heel. And this is a patient who comes in our office that has a very common occurrence, and this goes back to the question of Achilles tendinosis. And typically you'll come into our office and Dr. McCarroll and I will say, well, this is a situation where we really need to get a good look at the picture. And as Dr. McCarroll was saying, our Achilles tendon is typically very black on the MRI, and Dr. McCarroll pointed out there.
And also take a look at the difference in size.
Yeah, so
normal.
If you were to look at it up here versus right here, you can see the difference in thickness. This is how it's supposed to look up here, and then way down here, and then in the middle, in the body of the Achilles tendon. And this body area, which is about 4 to 5 centimeters above the heel, is called the watershed area. And that's the area of the Achilles tendon where there's the least amount of vascular supply to the tendon. So that's where everything goes wrong when it goes wrong. And what will happen, tendinosis is unique in the sense of tendonitis, because tendonitis has blood supply going to it, and it makes it red, hot, swollen, and inflamed. When we think of an itis, you think red, hot, and swollen. When you think tendinosis, the first thing that we think about is hypovascular, meaning there's very little blood supply. And because there's little blood supply, you're going to get more scarring. When you get scarring, you get a thickening of the tendon, you get that graying or whitening of the tendon on the MRI, and it hurts. And this is a classic scenario, and this is a picture of a patient that had one on a different type of MRI or a different image on the MRI, where you can again see how that black tendon has gotten very thick and is starting to get speckled white on the inside. That's that scar tissue that builds up. And when you think about tendinopathy, which is a blanket term that means, the affect of a tendon, whether it's on your arm or whether it's on your ankle, Achilles tendinopathy can affect 30 to 50% of all sports injuries. And it's a very common injury that we see for people who have an active lifestyle, whether it's outside of work or in work. So with that being said, Dr. McCarroll is going to start out by telling us a little bit about how he treats this condition, both conservatively and surgical, and then I'll kind of tie that in and tell you the nuances of how we treat it, and then we're going to have AJ talk to you a little bit about the conservative approach as well.
The interesting thing, Steve, can you go back to that MRI shot?
Sure.
What I generally try to tell people in the office is, this is your body's natural response. Okay, the tendon's under more stress. The tendon is actually made up of collagen, which is a fiber that's in strands. Kind of looks like linguine strands when we operate. That scar tissue in there, you can actually see within or in between the strands. Well, it's kind of like cotton balls. You got all this tendon that's a bunch of strands of cotton thread, and you're laying cotton down in between. That area of scar tissue, when that person heals, that whole tendon will be solidly black again. Okay, so that cotton, that extra scar tissue, actually matures into a tendon-like substance. So if AJ does his job, if we would MRI this 6 months or a year later, it's going to look all black. I mean, you can actually see the MRI shows the physiologic response as to what's going on. So MRI is very, very effective, with this. And from a conservative standpoint, there's really 2 ways to go. Okay. Often we see people for second opinion standpoints all the time. Okay, so somebody may say, well, we've done 6 weeks of therapy, or we've done a period of immobilization and a boot, both of which are actually correct. You can treat somebody like an older person, maybe with immobilization, and have this calm down. But that doesn't address the root cause. The root cause, as Dr. Brigido says, is that abnormal blood supply, which I don't have any control over. And
Nor do you.
Yeah. So. Or the degeneration over time, okay? So, what happens there is that's degenerating usually because it's too tight. So as we go through the exam, and I think at the end here, AJ can show us how to address that or how to look for that tightness, but it really comes down to a degree of tightness. I can't tell you anybody that I see with this problem who doesn't have Achilles tightness. It just doesn't happen. Well, I might think of one, okay? But that was a gentleman with very poor blood supply, okay? This is a purely a response to abnormal physiologic stress, which means it's, for the most part, preventable.
So wearing these compression socks during exercise
won't do a thing.
Won't do a thing.
Won't do a thing.
No.
No, won't do a thing.
No.
No. So go ahead.
No, go ahead.
So, you know, from this standpoint, as soon as somebody comes here into my office, I'll normally MRI you at first. I want to know how bad is it. Okay. Now, if I see this and this is all really thick and gray and there's a big white partial tear in it, I might immobilize you for a period of time. If it's just all this stuff here, just some diffuse graying and thickening, well, I'm going to send you to the therapist. And this is hard because he's going to have to stretch an already thick, sore, inflamed structure slowly over time to get it back out to what we call physiologic length. Okay. So it functions normally, but not get you so sore that you can't walk or not get it so sore that it ruptures.
And it doesn't happen quick.
So it's a tough deal.
Yeah.
You know? And that really puts a lot of onus on the patient because nowadays, and I wasn't going to bring this up, but you know, I just had this today with a patient. Some of these insurances, now it's a $50 copay. Let's be honest, a $50 copay for each therapy visit. So a lot of times he has to run the ship. Bring you in once a week. Say, these are our next week goals, bring you in next week, this is our next week goals. It can be a very, very slow process. So it takes a lot of mutual understanding as to what the goals are, maybe 3 months down the line or 4 months down the line.
Yeah.
So again, here for me, it's all either degree of damage, immobilization versus rupture, or versus therapy.
This is a condition that, although I may wake up tomorrow and start to feel this condition tomorrow, this has been happening for the last 3 or 4 years of my life. And when we come in, if I have this condition and I go see Dr. McCarroll with this condition, and I say, okay, we're going to do the therapy and we're going to do X, Y, and Z to get to make this happen. I'm going to have my home stretching program. My mentality, and for those of you in the crowd that know me, is I'm very much a kind of let's get this thing moving type of personality myself. As I'm the worst kind of patient for me, and but I have to think and I have to say this is something that has been biomechanically occurring in my body for the last 3, 4, 5, even 10 years, and this is something that has slowly, gradually built up over time. So for us to ask this to get completely better in 4 weeks, when we think logically about it, is probably a little bit unreasonable. Now, with that being said, we'll have patients that come to the office and go, you know what, doc, I feel great. I feel 90% better in most of the activities I'm doing after something as simple of a 3 to 4 week regimen of a good, dedicated stretching program. So, while it can be an injury that does take a little bit of time to treat when you're treating it conservatively, it's one of those injuries where you're not going to get instant gratification, but you're going to notice the results pretty darn quick. And in the beginning, it'll be where you'll see AJ and he'll stretch you out and you'll feel great for 2 days, but then it'll start to creep back. But then shortly after that, it'll feel better for 4 or 5 days. And all of a sudden, it'll feel better for 10 or 15 days. And all of a sudden, you're really getting some progress. And even though the Achilles tendon is so strong and those muscles are very, very strong, because the quality of the tendon typically is so healthy, we can really stretch this thing out, and you'll get a nice response on when it lengthens, it'll stay lengthened. And it's not something where you're going to have to keep coming back into the therapist every year to get this done. Once you get to the point where you're stretched, for the most part, you're going to be good with this. But it is something that can definitely hurt. AJ, do you have any comments on what are our approaches for when I send a patient to you with a chronic Achilles tendinosis? How do you guys what's your main goal from, say, the first week to the 4th week?
Well, I guess the main goal we have is to try to get the pain under control as fast as we can. I mean, that's the reason that people go to see the doc. It's not because they feel that they're tight, it's because it's hurting. So the one thing we can try to help for you is as quickly as we can to try to start getting that pain rolling in the right direction. And I think Dr. Brigido said it very, very well, because the stuff we do, the stretching we do, will initially have a small effect. Okay, it will help you for a day or so, you'll feel good for a little bit, and then it will return back and be a little sore for a while. The more we stretch it, the longer that period of good feeling will last. And eventually we'll get to the point where it's not giving you that discomfort anymore, and you'll be able to resume pretty much everything you want to do. But again, so pain is the one thing we want to take care of, but what we look at a lot is trying to see how tight things are. But what we look for, without getting too technical, hold a bone on the top of the ankle, and then we'll have either the patient pull up or I'll manually push their foot up. What we're looking for is the angle between the heel here and the fibular head in the lateral part of the ankle, or in other words, the bone that runs along the outside of the leg, okay? So we use this bone, the prominence here, a prominence up here, and the edge of the heel bone to look and see what kind of angle we have. And for us, if it's at 90 degrees, that is what we call neutral, okay? Anything beyond 90 degrees, like we count them in solitary degrees, we look for about 10 degrees of positive movement above 90. So anywhere between 90 and 100, or how we report it to the doc, 0 to 10. And then, obviously, the other way we can look for is going down. But again, what the docs are talking about the most there, with that tightness in the gastroc on the back, this is the most important direction going up. This is the one that most people lose. Then people either roll their foot sideways in, sideways out, or, like Dr. McCarroll said, rolling the whole leg out to the side, which lends to a whole bunch more of problems you can get, as they mentioned.
So what AJ's saying is when the foot and the leg are at 90 degrees here, we want to get Dr. McCarroll's foot to come up 10 degrees past perpendicular. So we've got to get his heel to come his foot to come all the way up there. And if the Achilles tendon in the back is tight and it's pulling up this way, it's going to pull this dotted line down. And many times we'll see patients that come for their first visit and they're minus 10 degrees below perpendicular. So AJ's responsibility is then to take the foot from down here and get it flexible enough and get this thing stretched out in the back so that the foot can swing all the way up and get above that perpendicular line. So that is the sole goal that all of us have when we're treating any type of Achilles tendon pathology. You rupture it, we operate on a heel spur, we operate on, or we treat Achilles tendinosis with conservative treatment, whatever we're doing, our goal is to get you as close to that magic number as possible. And now some people are just not made to get to 10. Some people are 7. And some people are 6. But we've got to find that number that is right for you to be pain-free.
We'll go through stuff later then for showing how to do it. Okay. So Steve, when you surgically fix these, you know, we all have, I think we pretty much do them all the same way. Let's just touch on that real quick before we go on to the next one.
So I have 2 different paradigms that I treat. I break our patients down into 2 patients. The first patient is somebody who only has a little bit of speckling in their Achilles tendon and has failed conservative treatment with physical therapy and things of that nature, doesn't have a spur, just has purely tendinosis in the body of the Achilles tendon. If they only have a minimal amount of scarring, and when I say minimal, what I'm looking for is less than 50% of the tendon becomes scarred, we do a procedure called microtenotomy radiofrequency ablation. And what we do is we make a very small incision on the inside of the tendon, and we take a radiofrequency needle that's hooked up to this box that creates radiofrequency energy, and we actually poke the tendon at different depths 21 different times with this radiofrequency needle. And what it does is it kind of shrink wraps that scarring, and it helps zap the tissue to allow blood vessels to recruit to the area, help wash out the scar tissue, and allow for healing. Now, it is not a procedure that works in patients who are at the advanced stage. This is for somebody who's got a lot of pain, but the tendon still doesn't look all that bad. When they look bad, then what we do is a procedure where we make an incision in the back of the leg, we cut out this damaged tissue, and we excise it, and we sew the tendon back together, and sometimes we'll use a graft. And this is an example of a patient who has that. This is the back of the Achilles tendon exposed. We'll actually make an incision into the body of the Achilles tendon. We'll cut out the damaged tissue, and then we sew it back together. And in this instance, because we had to cut out so much, we put a little synthetic graft on top of it, and then we close it. And when we close it, the tendon is back down to its normal size, and all the damaged tissue is removed. What is your treatment paradigm for these patients?
Basically the exact same. The thing that I would want to stress, though, to everybody, and especially the ladies, that thickening is not necessarily fully addressed with this technique. All right, or any technique for this. You got to remember the same physiologic process. It's up to your body to heal this. Your body's laying down the scar tissue. So often after we debulk the tendon, we put a graft on it, we do all that stuff, your body may still respond by massive amounts of scar tissue. So I don't want any of the ladies to think that they're going to have this nice, pretty, slender tendon after this, like they have on the other side.
In fact, more of it may be thicker.
Right. In fact, you might
But it'll be uniform.
It'll be uniform, and it'll be thickened, and it'll look like a pipe. Okay? So my biggest thing is when I talk to the ladies is, listen, cosmetically, this may not be what you want. Functionally, it's going to be good. Okay?
You can, when we fixed this gentleman, you know, you sew it up, and we've got this graft in there. He had a thicker, uniform thickness to his Achilles tendon from basically the leg all the way down to the heel. But I could take that Achilles tendon and squeeze it as much as I wanted to.
Doesn't hurt.
You'd be like, hey, that's great.
Yeah.
You know, it's just like squeezing, you know, my Achilles tendon.
Yeah. So cosmesis can be a problem, and that's just something you have to be willing to accept. For most guys, it's not a big deal. You know,
the other thing is when we're talking about the radiofrequency ablation, and this is something that can be a wonderful minimally invasive tool to this type of problem, but we'll make an incision that's no bigger than those two little dots right here on the MRI. It's literally, I mean, as wide as my thumb. That's it. And we can go and do that procedure. The pain will go away, but oftentimes the bump stays. But again, you can squeeze the bump, and it doesn't hurt. You know, so you know, it's not as much about the cosmetic look as it is making sure that tendon is, one, healthy again, and two, you know, pain-free. You know, because if we do both of those procedures, we do an MRI post-operatively, say at 6 months post-op, hypothetically if we had to, and that tendon, you're going to look at it, it's going to be nice and black and uniform. It may be thicker all around, but it's going to be healthy again.
You're going to see that solid black color again.
What's the recuperation period when you had that surgery?
It depends upon the severity. I'd love to say that this is a cookbook or a recipe that we can tell everybody it's always the same. But, you know, I mean, I really tailor that to the individual. If it's really bad, I may say, listen, I want you off of it for 6 weeks, almost like a rupture. If it's minor, I may say, hey, stay off of it for 2 weeks. Things are going to be fine. But it really comes down, what do you do for your radiofrequency? How long do you sit on them?
We are, for the radiofrequency, the small incision with the poke holes with the needle, we're off for 1 week on crutches, and then we'll have you walking in a boot for about a month. It typically, you'll notice about a 5 to 10% improvement every week after that. You know, we tell our patients, this is not something where tomorrow you're going to wake up and be like, ta-da, it got better. This is something where you're going to feel the benefits and how it worked 6 weeks later.
And for the surgery, how long are you out for surgery? Minimum.
Out meaning?
Out of competition.
Out of competition. I tell you 3 months. That, well, and we would clearly have to define competition, but I tell you can start training again, depending on the severity, 6 to 8 weeks. And I tell you can go and run competitively at 12 weeks. You had a question?
Did we just hear 3 procedures or 2 procedures?
2. The open, kind of like you saw in the pictures, and then the other one's the radiofrequency needle, which is the more for the least for the tendon that has the less amount of scar tissue in it.
My preference is generally to open, just because normally by the time I see them, that's kind of where we are. I'd love to say we get the athlete early on, but most people suffer with this for months before we ever see them. So, yeah.
I would say in my practice, athletes tend to get the open repair a much greater time versus people who typically have pain at work tend to, and there's no rhyme or reason for this, this is just what I see in my practice, I tend to do more radiofrequency procedures on people who have pain at work versus somebody who's an athlete. If I have a runner coming in, they're typically people who try to at least run through it for a period of time, and that makes the scar tissue build up more. So they tend to be a little bit more of an open procedure candidate than somebody who's perhaps not a runner or you know, not playing basketball 4 or 5 times a week, or you know, whatever type of situation it is. But patients do. These are both of them are very reliable procedures. People tend to do very well. The key is patience. Again, this is something that built up for 3 years. We can't ask it to be 100% in 4 weeks. So,
We'll hit the spurs.
this is sure. You want to go over that one?
Yeah. Now this is very common. I mean, when we talk about The lady coming in and says, I can't wear my shoe anymore. It hurts in the back. I got this big lump that's developed. But really, we see this equally as commonly as men, purely because of the tightness. And these are traction spurs. They're pulling spurs. That Achilles is so tight, it pulls on the covering of the bone. It irritates the bone. Bone cells only know how to do one thing when they're irritated. They make more bone. And in this case, they make the bone in the pull of the direction of the Achilles. So, you know, other places, like people say, well, I had a spur in my shoulder, and they went in with an arthroscopy, and they just shaved it down, and boy, that was slick. I was back, did 2 weeks of therapy, and I'm back playing tennis. That's not the case here. These spurs are inside the tendon, okay? There is no way to get to them without detaching a portion of the tendon, all right? So immediately when you start to address these surgically, you have a problem, okay? So again, what do? What's the same pathologic process we just covered for tendinosis, all right? We do the stretching, we do the ice, we do the anti-inflammatories, we try to get this thing stretched out, and often it'll calm down, okay? But the problem becomes is when you can't get that to calm down, this now is a much different problem.
How do you diagnose them? What tools do you use to diagnose these?
Yeah, these are something very easily diagnosed by X-ray. Not every one of these needs an MRI. However, okay, you get the X. Do you have an X-ray up, Steve? Next.
Yep.
Yeah. So you know, you look at this and you're like, X-ray. Well, you don't have to be a doctor to see that. I mean, doesn't you know, that doesn't take a medical degree to see that spur there. The problem, though, again, is it's in the tendon. Okay, so we know what the problem is. We know what the treatment is conservatively. We've been through all that. I don't think we really need to so much stress on that again. I personally never inject these. You'll find people in the community that do.
Never let anybody come at you with a needle with these, please.
They usually will rupture.
They will rupture.
Okay.
We have both fixed numerous patients where they were getting treatment. Somebody gave a cortisone injection around the Achilles tendon. The next day they woke up, took a step, and boom, it goes.
I was trying to be nice about that, but you hit the nail right on the head.
Never let anybody, you can try anything you want. Never let anybody put cortisone around an Achilles tendon. It is a disaster.
So when we look at these, it's very straightforward. The patient understands it, the therapist understands it, the doctor understands it. We've just entered all the same conservative treatment that we already talked about. The problem then with these, of course, is when that fails, okay? And there is a role for MRI because with these, often the MRI will show some concomitant micro tears, some maybe partial tearing in the tendon. It actually can change the surgeon's preoperative plan a little bit. So the role of the MRI for me here is preoperative planning, not coming up with a diagnosis. Okay? Go ahead.
Back to the warning about the cortisone shot.
Yeah.
Is that true of other tendons as well, or just the Achilles tendon?
Any weight-bearing tendon can have an increased risk, not ligament. Okay, not ligament. Any weight-bearing tendon can have an increased risk, depending upon how diseased or pathologic the tendon is, to rupture after cortisone. It is possible.
I would say the Achilles tendon, though, is probably 4 times greater risk than other tendons because the Achilles tendon has such a bad blood flow.
Yeah. And it also takes an exorbitant amount of stress. That tendon can take up to 4 times body weight, so you're asking it to do a lot more than I got to pull my finger up or I got to grasp a ball. Okay, so, all right.
Conservative treatments?
Same.
AJ, anything differ between this treatment for the tendinosis versus when you have a spur?
Not really. Basically, we're after that calf muscle, we're after the gastrocsoleus complex there. We're trying to get that more extensive, take the stress off the back of the heel, through the region of the spur, or through the tendon itself. So.
If I have a patient that has a spur on the back, as we saw in this picture, but perhaps they have a little bursitis, they had that little pillow that you saw in the first diagram was inflamed. Would you incorporate like ultrasound or electrical stimulation in the regimen to try to calm that inflammation down as well?
I definitely try to use the ultrasound, and especially when they have a spur like this. The good thing again is with communication we have, a lot of times we'll be able to see some of the x-rays that the doctors have, or they'll give us some of those things. But if I were to attack this with ultrasound, I'd want to come at it from the side. I wouldn't want to try to go through the spur with it. I wouldn't want to try to irritate the bone any more than it's already irritated. But if we come at it from the side, we'll be able to get to that bursa underneath that tendon without affecting that spur, and they should get more relief faster that way.
If we have an inflammatory state, and it would be one of those situations that we would like to put a needle into it, we'll use ultrasound instead. Ultrasound is an anti-inflammatory just like cortisone can be, but it doesn't have the detrimental properties to the tendon. So you can get the same physiologic benefits without the harm. So we'll try to incorporate that into the regimen when necessary. And a lot of patients, because of the size of the spur, and I'm almost, I can't remember who this person was, but by looking at the x-ray, but I can tell you that there would be days where that person would come in and that spur would be even 2 or 3 times bigger appearing, because that retrocalcaneal bursa, because of a spur that big, is going to get irritated and it's going to swell. And so one day that person may have put a shoe on and been very comfortable. The next day they wouldn't have been able to wear a shoe with a back because of that ebb and flow of the inflammation. So you'll find that sometimes when it looks like it's getting bigger one day and the next, the bone stays the same size. It's the tissue around it that's swelling.
The other thing with this is, and I don't want you to think that if you can't get better with therapy, there's not a consequence. You have to go to surgery. On rare occasion, especially for the ladies, you put them in a 3/4 inch heel or a 1 inch heel, the pain may go away, because you're actually asking that Achilles tendon to function about a shorter distance because you're jacking the heel up. The problem is you're stuck there. You can't wear flats, you can't wear sneakers, you can't wear sandals, you can't go barefoot, you can't do anything else without getting that irritated.
And sometimes you then have to progress to a higher heel and then to a higher heel.
So it's a self-fulfilling prophecy for kind of heading down a bad road.
Yeah.
So some doctors will say, just wear a 1 inch heel, you'll be fine. Yeah, you'll feel great until that 1 inch heel isn't enough, and now it's a 1.5 inches, and then it's 2 inches. So
and the higher the heel is before you come to see us, the more work we have to do.
Right.
So.
Yeah, I would say that I don't encourage my patients to do that, just because I do feel it becomes this cyclical, Now, sometimes there are circumstances where we just can't fix it. You just had a bypass. We've got extenuating circumstances where we can't go and you're not the best surgical candidate. And if that's the case, we've got to do what we can do to get you comfortable. And we'll do heel lifts or things of that nature to try to make it happen. But if you have this long enough, eventually you're going to be walking around on stilts, because you've just got to keep shortening the tendon for it to get better. So, surgically.
I mean, we do this both the exact same way, okay?
And what we'll do is we'll actually incise the Achilles tendon. If anybody doesn't want us to show this, we don't have to show it. But we're this far already, so why not?
And the interesting thing is, where that linear cut is often on MRI from a preoperative planning standpoint. We'll often see tendinosis or scarring or micro tearing there.
The last thing that we'll show you before everybody decides to walk out on us is we have detached the Achilles tendon from the heel, so that it is officially removed. And we need to do that because we want to make the heel nice, and we sand it down and we buff it and we make it look the way it was designed to look.
Looks like a bald eagle, just perfectly round head.
Perfectly round, exactly. Yep. And then what we're going to use is what's called a bone anchor. And bone anchors are little tacks that have strands of suture that come off of them, and we use them to sew the tendon back down to the bone so it can heal the proper way. Once the Achilles tendon is sewn back together, and let me get you to the finished picture, because I just feel like you guys hate this.
The nice thing about this, though, by the way, and you may say, oh my gosh, that sounds aggressive. Once we remove that spur and everything back there, that is a raw bleeding bone surface, okay? And that really helps the tendon to knit and adhere, because it brings bleeding to the area. The body responds to that. It scars generally nicely. So everybody's kind of like, oh, that's bad. You got a raw surface there. It actually helps with everything. Yeah. You can't really attach a tendon well to a smooth surface. Okay, it has to be raw and bleeding to knit back down to that properly. So this technique with this, what we call a Mercedes incision, can address everything. It can address the tendinopathy. It can address the spur. It can give us the raw bleeding surface to reattach the tendon. It gives us everything we need to do to try to make that tendon healthy again. Okay? But then is the recovery. All right? And that's the hard part. And we both maybe vary a little bit in that. I'm extremely conservative. I've had a lot of people that misbehave. So for me anymore, 6 weeks in a cast, don't want to hear anything about it. Stay off of it. Let that tendon knit down to that raw bleeding surface. You get a DonJoy boot or a walking boot at that point. You start working with AJ. Over those next 2 weeks, he gets you to 90 to maybe +5. Then you go to a sneaker. And about 4 weeks after the surgery, you should be at +10 and feeling like, oh my gosh, maybe I'm happy I had this done. But that's at week 10. Okay? And then you might start at week 10 or 12 getting back into your training program if you have to. So I don't know, you may be a little more aggressive with that, or?
I am to a degree. I don't cast our patients. I do a soft dressing in a boot, and I have you non-weight bearing for 3 weeks on average unless there's extenuating circumstances. I start therapy at 3 weeks and do progressive weight bearing from the 3 point on. There's no right or wrong, and you'll find that each surgeon has his or her own nuances to how they approach the patient post-operatively. And it also depends on the kind of fixation that you're able to put in that patient as well. So that's why I don't like to give general blanket statements, because what may work for patient A may not work for patient B and C. But as a whole, I think at the end of the day, we're both, Dr. McCarroll and I are both trying to get each patient to the same end goal. And whichever route we take in that post-operative course, you'll find that at week 10, our patients are both pretty much doing about the same. It's just how he and I differ, and part of that is just surgeon personality too. So, but it's important to understand that maybe what worked for your neighbor isn't necessarily what's best for you, and vice versa. So that's an important aspect that we often will get questions about, because what maybe worked for one patient is again not the best thing for you. So
let's hit the last one.
Patient 3. Oh, sorry, go ahead.
Do you always remove part of the tendon when you do that surgery?
You always have to detach a portion of the tendon. The spur is in the tendon itself. So there's no way to get the spur out. Now on rare occasions, it'll just sit in the very back, like 1/10 of the tendon. So you can kind of go in there and just with an osteotome shave it off. And you may say, wow, 90% of the tendon's left. I don't have to use an anchor. But you still decrease the attachment of the tendon by maybe 10 or 20%. Yeah. So there's still a recovery process with that. It depends upon the size of the spur, the location of the spur, that type of thing.
So you're only getting rid of the part of the tendon that the bone spur is in?
That's been damaged,
correct.
Yes. Yeah. So in advanced cases, and typically most patients that have gotten to the point where it's surgical, they're advanced enough that they will have some tendon degeneration as well as the bone spurs. So when you're in there, our goal is to make it, as close to new as possible. So anything that's scarred and damaged that isn't healthy, we'll remove. We, 9 times out of 10, we'll detach the tendon from the bone and smooth it down, unless of course you do have that random spur that you can get to, in the fortunate situation. But again, that would be something that preoperative planning for both Dr. McCarroll and I is important, because you want to look at the 3-dimensional images that we get with an MRI and say, okay, we're going to go here. We don't need to go here. It's just like if you're flying a plane, you want to have your map. And Dr. McCarroll and I both plan our procedures. We don't go in there and say, well, this was the same for the last patient. Every patient is tailored to specific to what his or her needs are. And we preoperative plan and make sure that our approach is consistent. Yeah, that expression, everybody's a snowflake, really does hold true. Yeah. Okay? It's very, very individualized.
Question with that. So if you're removing the damaged part of the tendon too, like along with bone spur?
If present, yeah.
So that won't regenerate?
No, we sew it back together, and it does. And no. That, because typically, if you think of your tendon as a tube, you've got a dagger going up into that tendon, up into that tube, and that dagger has been there with every step you've taken for the last however many years. By the time that dagger gets pulled out, that tendon has just been eaten away to the point where it's unhealthy. So by removing it and sewing it together, that tendon then can regenerate, but it can't regenerate around it.
Thank you.
Yeah. So a patient typically between the ages of 30 and 55 is, say, out playing a round of golf and missteps, or playing softball, and as a base hits, running to first base, and it feels like somebody took a light broom and hit them in the back of the calf. It doesn't hurt that bad, but they know something's not that right. They can walk. Their leg is almost instantly swollen. They can't really go up on their tiptoes, and they come into the office, and we notice that they have a palpable deficit in the back of their heel. Where their Achilles tendon used to be, you can push on it and it's soft. That is the classic scenario that we feel with an Achilles tendon rupture.
However, not everybody fits that, because just last week, had a 70-year-old lady come in 3 weeks after, I felt a little soreness in my calf. She's been walking on that Achilles tendon rupture for 3 weeks and didn't notice a thing different. So don't think that you can't walk with an Achilles tendon rupture.
Yeah, almost. I would say that 90% of our Achilles tendon ruptures that we treat probably walk in.
Yeah.
Might
not be graceful, but they do walk.
But they walk in.
All right. So
because it doesn't hurt that bad, they go, hey, I really must have sprained this pretty bad. Yeah. And they walk in. And all of a sudden you squeeze their calf. It's called the Thompson test. If you squeeze the harder your calf, your foot should flinch down. If you're ruptured, you squeeze it and the foot just stays put because the tendon can't pull on the heel to make it flinch. And so the first thing we do is we lay our patients on their stomach on our exams table. First thing we'll do is we'll touch it and feel if we can see the gap, because if it looks like a duck and quacks like a duck, it's a duck. And and then if it's questionable, we'll do the Thompson test. And if the Thompson test is positive, then in my practice, you'll get an MRI, because again, I'm pretty confident that you and I are going to get to know each other really well over the next 6 to 8 weeks, and I want a preoperative plan and see how bad the Achilles tendon is.
That MRI is not for us to say you tore it.
Yeah.
That MRI is for us to come up with a plan as to how to address it. And as we go through this, what we're talking about now is a fresh rupture. All right. Again, not to bring up socioeconomics again, but we got a lot of guys out there that are having a hard time maintaining a job, or the families are having a hard time financially. The number of people now that we're seeing coming in 4 months later, which is a whole different lecture in itself as to how to address those. You come in 4 months later with an Achilles rupture. Now we have a whole different set of tools to use, okay? And it's much, much, much more complicated. Okay, so while we're talking about the simple stuff here, this could get so involved that you're talking cadaveric grafts and tendon transfers and all sorts of other fun stuff, when these get out there too far. So I don't want you to think that, one, you can't walk on it, and two, hey, it's sore and it really hurts, but I'm going to wait 4 or 6 weeks to go see the doc, because you've just complicated your life, and you complicated mine a little bit too. All right, because now I have to use techniques that might not get you quite back to where you are, or it might take 6 months to get you back to where you should be.
So if you have a concern,
see us, or see somebody.
See somebody. Absolutely.
Just an added thought on that too, when you talk about the muscles as well. If you're sitting for 4 to 6 weeks before you go to see these guys, your muscles that are no longer attached are not going to be working as functional. I mean, they still have their innervation. They'll still be able to get the signal from the brain to contract, but they have nothing to pull on, so they're not going to work very hard. They're going to be lazy, they're going to shrink. So then when they do put them back together, then they send you guys to us. These muscles are far worse than if you had gotten to them early.
This is a 28-year-old lady, was in Florida on vacation and slipped off a curb. And no health problems otherwise, very active. I believe going to grad school, and she slipped off a curb and sustained a full thickness Achilles tendon rupture. And an Achilles tendon rupture will typically look, and this picture actually doesn't do a great job at depicting it, but if you think of a typical janitorial mop that's made of rope, that's typically what the two ends of the Achilles tendon, when it ruptures, will look like. You will see 2 mop handles. And what we have to do is actually resect and cut those mop handles off. And then we'll have our surgical fellow, Dr. Bleasy, will tell him to start water skiing. And what we do by water skiing is we put suture through the upper muscle. So your head is up here, and then this is a leg, and the heel's down here. And by putting suture on and holding it, what we're doing is loosening this calf so that we can connect point A and point B again. Because remember, when you blow that out, you blow out and you create that mop handle, that's unsewable. We have to remove that. So we have to take a gap that's, in many instances this big. But the beauty of it is our muscles are flexible enough, so when we're riding that and holding onto it and water skiing on that muscle, we can pull that down, and then we can get to the point where we have the tendon sewed back together like you see here. And it is something that I don't think we have a whole lot of difference in our postoperative course with these. These are pretty standard, but you're typically going to be immobilized in a splint or a cast for typically a month to 6 weeks, depending on the quality of your tissue, how bad your tear was, and where your tear is located, and then you're going to see AJ, and you're going to see him for probably a couple months. And you're going to be able to build yourself up in strength and activity. And you're going to be able to do this. And ideally, we have our patients get back to running and basketball and softball and all the things that he or she likes to do. But it's a road where NFL players who have round-the-clock medical treatment 24 hours a day supplied by the team, if you rupture your Achilles tendon in August, you're probably not playing again until the following July. So it is something that does take time to build up your strength, and even in the patient who is in the best physical condition of arguably anybody in the world.
And these are each different too. I mean, if you get one of these that are torn high off the muscle, you ever kind of sew through something soggy? That's what muscle's like. It doesn't have a lot of substance. So you may have a very high tear here, and we may say, listen, you're going to have to add another 2 weeks to that immobilization, or you can tear these right off the bone. Okay? And one of the things you got to remember is people that tear these, they're normally tight to start with. So now we have a tight muscle that we're starting with. We're trimming ends. We're bringing maybe a 3 centimeter gap together. Now they're super tight. Good luck, AJ.
Yeah.
You know?
So we'll often cast patients with their toe pointed down, and then it's AJ's job every time we get he or she into physical therapy to gradually bring the foot up to 90 degrees again so it can walk. But the first time AJ sees a patient, depending on the tear, their foot may be pointed down in the ballerina position, and then it's therapy's responsibility to gradually bring it up.